we're discussing IVF and miscarriage, reducing risks, providing support. The hashtag is IVF miscarriage. So for some background first, what is a miscarriage? Well, a miscarriage is usually defined as the loss of a pregnancy before the first 24 weeks of that pregnancy. And miscarriages, unfortunately, are much more common than most people realise. According to NHS Choice's website, among people who know they're pregnant, it's estimated about 1 in 8 pregnancies will end in miscarriage. And in a survey which was carried out by Tommy's, half of adults in the UK said that they or someone that they know had experienced pregnancy or baby loss. Most miscarriages happen in the first 12 weeks of pregnancy, and they're often referred to as early miscarriages. And it's estimated that early miscarriages happen in about 20% of pregnancies. And it's estimated that second trimester loss, so-called late miscarriage, happens in 3 to 4% of pregnancies. Again, according to NHS Choices, losing 3 or more pregnancies in a row, recurrent miscarriage, is uncommon and only affects around 1 in 100 women. That actually sounds quite common to me. But we should also be aware that many more miscarriages happen before a person is even aware that they're pregnant. All miscarriages can be very upsetting for the woman and her partner. And I think it's important to understand as well that fertility treatment doesn't protect against miscarriage. That's sometimes a bit of a misunderstanding that people have. And fertility patients who have a positive pregnancy test at the end of the 2-week wait, at a very exciting and nerve-wracking time after their embryo transfer, they can become aware that they're pregnant at a much earlier time than people who conceive naturally. And this knowledge, combined with a history of struggling to conceive, can make losing a pregnancy very upsetting for those patients. Now, I want to be really clear that in saying that, I'm not in any way, shape, or form setting up some form of miscarriages as more emotionally significant or impactful than others. Everyone is affected differently by these things. But unfortunately, guilt often accompanies grief, and questions of what if sometimes can become all-consuming. And I just wanted to be clear at the outset that by discussing how to reduce the risk of miscarriage, tonight's speakers are not apportioning blame to anyone. They're not finger wagging. They're trying to provide advice to patients and professionals alike so that people can find a way forward that is appropriate for them. So it gives me great pleasure now to introduce tonight's first speaker, Andrea Woolner. Andrea is early pregnancy lead for NHS Grampian and honorary consultant obstetrician at Aberdeen Maternity Hospital. She is a senior clinical lecturer in obstetrics and gynaecology at the University of Aberdeen Centre for Women's Health Research.
As Sarah has said, I work in Aberdeen and work both in research as an academic clinician, and my research interests are all really about adverse pregnancy outcomes and pregnancy loss in particular at any stage of pregnancy. I am an obstetrician and I am the early pregnancy lead and work in the early pregnancy unit in Aberdeen, and I also help to run the recurrent miscarriage service in Aberdeen as well. So I'm tasked, I guess, tonight with talking about my area of interest, which is early pregnancy. I'm not a fertility specialist. I'm not involved directly in fertility investigations or IVF treatment. I work primarily, as I've said, as an obstetrician and in the early pregnancy unit. So I thought I would start by just going over, well, what is an early pregnancy unit? Because actually for many couples, and particularly couples who have perhaps been through fertility services and had IVF, they may not have come across an early pregnancy unit before. And early pregnancy units are quite a UK thing. They're not that common outside of the UK. I believe Australia is now starting to have much more EPUs, as we call them. But it's very much a UK thing, and it's a specialist service that is for pregnant people to present to in the first part of pregnancy with complications. It might be bleeding, it might be pain, sometimes it's severe nausea and vomiting. And across the country, who is seen and when they are seen in an early pregnancy unit does vary. Some units will see only women up to 12 weeks of pregnancy, some will see up to 16. In Aberdeen, we're quite unusual. We see women in our early pregnancy unit up to 24 weeks, and it's also co-located with our later pregnancy loss bereavement suite as well. So I mentioned that we see people come to an early pregnancy unit at various different times of pregnancy, but ultimately all early pregnancy units are focused on seeing women who present with complications such as bleeding and pain, or suspected, where they've suspected of breaking their waters at a very early stage. So that brought me to, well, actually, what do we know about early pregnancy? And I thought I would share a little bit about that. How do we know what's normal in early pregnancy? Well, again, we know a little bit about early pregnancy, and more in recent years because of ultrasound scan. And we can use ultrasound scans to identify where a pregnancy is, and that's really important in an early pregnancy unit, because one of the things we are checking for is a different complication called ectopic pregnancy. We're also checking whether or not that pregnancy is growing as we would expect it to. And that's important to either reassure that it is growing properly and as we expect, or in the case where we sometimes sadly diagnose miscarriage. So we know that around 5 weeks of pregnancy, you can start to see a pregnancy sac on a scan. And whilst I'm laying this out a little bit like it's a textbook, and at this stage you'll definitely see this, it doesn't always work perfectly like that in early pregnancy. And the structures that we're scanning, this pregnancy sac I mentioned, and we can see within the uterus, can be absolutely tiny to begin with. We're measuring things that are only millimeters in size. We know that once there's a pregnancy sac, the normal development would then be to see what we call a yolk sac. So a small circular structure within the first pregnancy circular structure usually we see in the womb. And that's a normal feature. After that, and this is all between sort of 5 to 6 weeks, and up to 7 weeks, we will then hopefully, if the pregnancy is developing normally, see what we call a very clinical term, fetal pole, and you might see that in ultrasound reports. But of course, that is what is developing into the baby. And then by 6 to 7 weeks, we would expect to see a heartbeat within the baby. And importantly, there is if you like, a threshold of 7 millimeters, which is where we would expect to see a heartbeat. And if we haven't seen a heartbeat by that time, that would confirm to us that there unfortunately is a problem, and that is when a miscarriage can be diagnosed. Now, that's a simplistic view, but hopefully that just gives you an idea of the sorts of things we're looking for when women come to an early pregnancy unit. And again, just to emphasize the types of things that we are scanning and investigating at this stage, 7 millimeters is not even the size of your thumbnail. It is absolutely tiny structures that we are measuring. And we can use transabdominal scans in the early pregnancy unit, but actually quite often what we need to use is a transvaginal scan to get that better imaging of the womb and the structures inside the womb. So one of the commonest reasons people come to an early pregnancy unit is early pregnancy bleeding. And up to 1 in 4 pregnancies, women will report that they've had bleeding in the first 12 weeks. It's quite a lot, 25%. There's not whole population estimates, but certainly that's a rough guide from what we know from the existing literature that's out there, that it's roughly 1 in 4. And actually the vast majority of people who come to an early pregnancy unit, in our unit, we audited, and I'm sure it was around 80% of people who came through the doors actually had an ongoing normal pregnancy. So very reassuring. And again, similarly with bleeding, actually a number of people who do have bleeding, it doesn't mean that there's a problem per se. The pregnancy can be ongoing. Of course, it's very scary to see bleeding, and absolutely acknowledge that unfortunately and sadly in a number of cases we will find a complication, and that may be miscarriage. It could be something else as well, like an ectopic pregnancy. We can now, in many units, are adopting now NICE guidance, so National Clinical Guidance, that came out in 2021 following a robust clinical trial which suggested that progesterone can be used for some cases of early bleeding where women have had previous miscarriages. And importantly, that's after an ultrasound scan has assessed the features of your pregnancy and determined that it's safe to do that. And ultimately, as I've mentioned, and very sadly, sometimes we will find that the pregnancy is not ongoing. And it might be that there's been bleeding that's instigated the referral. It could be pain. And sometimes, unfortunately, there are no signs. And sometimes that miscarriage actually happens with very little symptoms at all. And we do have women who will then be diagnosed with a miscarriage when they attend their 12-week scan. Now, for couples who've had IVF, they'll usually have had a scan around 7 weeks, and all being well and confirmed pregnancy's in the correct place and is ongoing and has progressed to the 7-week stage. Sometimes there won't be another scan after that, and it is unfortunately sometimes possible that a miscarriage will still happen when you attend a routine scan later in the pregnancy. Miscarriage is unexpected, I find, whether that's after IVF or after a spontaneous pregnancy. Even in people who have not planned their pregnancy and may even be uncertain about their pregnancy, it is often unexpected. And unexplained is something that I think is really difficult about miscarriage. We know that a number of miscarriages are due to something genetic, something in the makeup, if you like, of when the sperm and egg have fused and become one, something is not right. And that unfortunately means a miscarriage will happen. But that also means in around half of miscarriages, we don't really know why. And unexplained in the sense that we also don't test every miscarriage in the UK to understand what has happened. Miscarriage can absolutely be upsetting. And I think there's no right or wrong way to feel at the time of a miscarriage or after. I think language is really important. And I think we as clinicians don't always get it right, in the sense that some people will very much want us to refer to the baby and a baby. However, other people don't like that, I find, as well, in my experience, and prefer us to use terms such as the pregnancy. And it is, as I say, there's no right or wrong way to feel. I think it's also unspoken. I think miscarriage still in our society, it's much better nowadays, is a very unspoken thing. People don't talk about it. You'd probably be surprised how many people you know have been through pregnancy loss and very early pregnancy loss, and particularly very early miscarriages before they can even be seen on a scan, which we sometimes call biochemical losses, where you've had a positive test, but the pregnancy is too early to be seen in the scan, again, are even more common, but yet are things that people often don't talk about. So how do we diagnose miscarriage? Well, I've mentioned already, we have certain, I guess, if you like, measurements or thresholds that we know beyond a certain point that we should be seeing more. And time durations where if after a week something hasn't changed, hasn't grown, hasn't developed, we again know that unfortunately that is associated with the pregnancy not progressing, and we can diagnose a miscarriage. It can be really hard because what, as clinicians in the early pregnancy unit, we want to be really sure of is that we are correct in our diagnosis. We want to be absolutely sure that we are giving you an accurate diagnosis. I've mentioned we're measuring very tiny structures. Things change over time in that early pregnancy period at speed, but that sometimes still means that we want and we will recommend a scan in 7 to 10 days, depending your unit. Protocols will vary, but essentially it's quite common to need a repeat scan to confirm miscarriage. I've mentioned transvaginal is more accurate generally than transabdominal, but we tend to use a combination of the two. And again, it will depend about your particular individual circumstances and why we might use both or one or the other. There is uncertainty, I guess, in terms of our diagnoses, and that's why we have these guidelines from a national perspective. There are guidelines there that have been built upon by research that's been done before to say what are safe thresholds, because again, what we don't want to do is diagnose a miscarriage, but more importantly, give treatment that would end a pregnancy unless we are absolutely certain that we are correct to give that sad news that the pregnancy is not progressing. And I've mentioned biochemical losses already. Again, I've mentioned I'm not a fertility expert, I'm not an IVF expert, I'm a general obstetrician. But I think, again, from my perspective in the early pregnancy, I think miscarriage after IVF can be confusing. I think the dates can be confusing. The need for repeat scans can be really confusing, because up until that point, you will be very aware, if you've been through IVF treatment, about the stage of the embryo, of how many days you should be. And it can be really hard then when we're talking about whether or not the pregnancy is continuing and thinking about dates when your transfer dates are so certain, if that makes sense, which is different for spontaneous pregnancies. And I think that can be really hard. You may be meeting a completely new clinical team, being in a completely new area, and deciding upon treatment, which I think nobody really wants to be having to decide about and going through, whether after IVF or a spontaneous pregnancy. And I think that's really hard. I think that it's ultimately not where anybody wants to be at that point. And I would say that I would encourage people to know that the early pregnancy units are aware of that, and we're there to support you through this difficult time. I mentioned there is a choice of treatments, and I won't go into detail, but I'm happy to answer questions if that's helpful. But having a miscarriage, and then if the miscarriage doesn't happen by itself, i.e., sometimes the pregnancy is still inside the womb, there are risks and benefits to the 3 different options for miscarriage treatment. There is no best treatment I'm aware of at the moment from current evidence. And again, we're there to support you through and help you to make which decision is best for you. But again, after IVF, again, particularly when you may have already had lots of investigations, you may have had lots of information about your reproductive organs, thinking then about something that can cause complication to your womb can be really difficult and hard to process. After loss, we know that miscarriage can absolutely have a psychological toll on women, their partners and families. We in Scotland have the Scottish National Bereavement Care Pathways, and there is UK-wide ones as well, which are, again, clinical tools, if you like, or a guideline for us to be helping couples through this loss. And also we have fantastic third sector organisations and charities that provide support to couples after miscarriage. So I'm not going to talk a lot about recurrent miscarriage, because I know Cheryl, who is the next speaker, is going to talk about this in a lot more detail. But I guess I just wanted to mention a couple of things. That having 1 miscarriage is really very common. Having 2 is also quite common. Having 3 or more consecutive miscarriages was traditionally, if you like, where the definition of recurrent miscarriage came from. But nowadays that's a little bit more fluid, and many clinics now are seeing women after 2 miscarriages. We certainly do that in Aberdeen. It doesn't mean that we'll find anything different than if we'd waited till after a 3rd loss, but again, there is this recognition of the impact that having repeated miscarriages has. And we offer various different investigations that are based on, again, national guidance, and include things such as looking for maternal conditions and shape of the womb, and doing genetic testing after a 3rd miscarriage. And I just wanted to finally end with, obviously the session tonight is about miscarriage, and I'm not meaning to take away from that in any shape or form. But there are also lots of other early pregnancy complications that can occur after an IVF pregnancy and after a spontaneous pregnancy as well, that can be very distressing and difficult. One of which is pregnancy of unknown location, which can be a really difficult, drawn-out process where sometimes we'll never know exactly what's happened to the pregnancy. Ectopic pregnancy, and also gestational trophoblastic disease as well, which is rare but again can happen, and pregnancy loss. In terms of preventing early pregnancy loss, it's not always possible to prevent all these different types of early pregnancy loss, and unfortunately, again, IVF doesn't protect against such pregnancy loss. And I know Cheryl's going to talk to us a little bit more about things we can do for recurrent miscarriages, but I guess my only final comment was just emphasising what Sarah said earlier about blame. There is no blame here. Miscarriage is very common, and I think we talk about things to prevent and reduce the risk. And again, I won't go into detail, but again, just remembering that that's not to say that that was the reason previous miscarriages happened, but trying to optimize your health for pregnancy is really important for fertility outcomes, but also the rest of your pregnancy as well as the early stages. So things like stopping smoking and such are healthy for you and pregnancy.
Cheryl is a consultant in gynecology and reproductive medicine at the Royal Infirmary of Edinburgh, and she was part of the team that performed the sort of groundbreaking surgery, the reimplantation of cryopreserved ovarian tissue in the UK, and she was a contributor to the book Cryopreservation in Assisted Reproduction. But it's not really that she's talking about tonight. She's a woman of many talents.
So yes, I work in Edinburgh, and although I'm not a recurrent miscarriage absolute expert, I deal with recurrent miscarriage a lot, and part of my role is actually providing consultant support to our local early pregnancy unit and doing a lot of linking between our local recurrent miscarriage clinic and our early pregnancy unit. So it's something I deal with very frequently, and so that's what I'm going to talk to you about today. Recurrent miscarriage can also be termed recurrent pregnancy loss, and that's how I've referred to it during this talk. And I've also kept the discussion regarding really first trimester losses, and that's because within the IVF setting that's really what we are managing and investigating. So as Andrea said, the definition of recurrent pregnancy loss is not concrete anymore. And within the UK, NICE guidance has stated that it should be defined as being 3 or more first trimester miscarriages, as have the Royal College of Obs and Gynae, although they have now recommended most recently in their guideline that we can start investigations after 2, just as Andrea is doing in Aberdeen. However, European guidance from ESHRE does define it as being 2 or more first trimester miscarriages, although within the UK we're still working to our NICE and RCOG guidance. I thought I'd start with what the experience of recurrent pregnancy loss is like following IVF, both for patients and for staff. And I absolutely cannot speak to everybody that's had recurrent pregnancy loss, but these are just sort of common themes that I've experienced in managing patients with this problem. And so patients, as Andrea said, this is a real feeling of grief, a real feeling of loss, and often a feeling of hopelessness. These are couples who have already been struggling with fertility in the first place, and then they finally get pregnant, and this awful outcome of miscarriage occurs. And so it's a really draining and difficult time for these couples. It's unexpected. It's unexpected for those with natural conception, but especially when we do IVF, we're putting back good quality embryos, and couples think, how on earth can this have ended in a miscarriage? And unfortunately, as Sarah said at the very start, unfortunately, IVF is just not a treatment for miscarriage, and it does not reduce your chance of having a miscarriage. So we have to, very sensitively explain that to patients. Having a miscarriage delays your treatment, and I would say this is one of the real sources of frustration for couples. So the whole management of having a miscarriage, the diagnosis, the management, the physical and psychological impact of having a miscarriage delays being able to proceed with your next treatment cycle. The investigations that we perform for recurrent pregnancy loss can take time to come back. They sometimes need to wait several weeks after a miscarriage before we can even do them to get a reliable result. And so all of these things stop you then being able to go on to the next stage and can be hugely frustrating for couples. There's a loss of control around the whole thing. Already these couples have felt a loss of control of their bodies about the fertility journey, and now they feel a loss of control over a loss of a pregnancy. And there's a lot of having to cope with diagnostic uncertainty, whether that's not actually being able to diagnose the miscarriage. As Andrea was saying, sometimes this can take several scans, several blood tests for us to be able to say this is definitely, unfortunately, an unviable pregnancy. But also the diagnostic uncertainty of why is this happening? Why am I having miscarriages? And patients do their research, and they go down a lot of rabbit holes on the internet, and you can find whatever you want to be able to find on the internet. And unfortunately, that can often cause a lot of concern and for anxieties for patients as well. From the staff point of view, we often feel really powerless, actually. We don't have a lot of investigations we can perform. We don't have a lot of interventions that we can effectively introduce. And often it's really difficult to be able to say to a couple, I don't know why this is happening, and I have nothing I can help with in order to make this not happen again. These consultations can be very difficult, very emotional, and there can be a lot of conflict between what a patient has researched and would like us to do and actually what we are ethically should do from an evidence base, and also what we're allowed to do within an NHS system. And the counselling can be really, really challenging. So sometimes we have absolutely no idea why people are having a miscarriage. And also, we can often not really tell them what their chances are of having a live birth, a baby to take home in the future. The ESHRE guidance quotes this paper from Katy et al. And basically it shows the chances of having a live birth depending on maternal age and the number of prior miscarriages in the next pregnancy. And you can see here that if you're 25 and you've had 3 miscarriages before, we actually can be really positive about the chances of you having a live birth in the future. But if you're 42 and it's your 5th miscarriage, it can be more despondent reading this kind of chart for counselling. So what can we offer our patients? Well, NICE, RCUG and the ESHRE guidance all concur on the following. So we should assess lifestyle, and improving lifestyle can reduce the risk of a future miscarriage. And again, this is not finger wagging, as Sarah was saying, but it's just general advice that we can give patients that might help things in the future. So maintaining a maternal BMI between 19 and 25, stopping smoking, limiting alcohol and caffeine intake, so caffeine intake to less than 200 milligrams a day. We can also perform testing for something called acquired thrombophilia, so sticky blood disorders, as we would say to patients, and that is something called lupus and antiocardiolipin antibodies. And we can test thyroid function, including tests for antibodies against the thyroid, which is called an anti-TPO antibody. We should be assessing all of these women for uterine anomalies, hopefully by a 3D ultrasound scan, preferably. And after the 3rd miscarriage, we should be sending any products of conception from a miscarriage off for genetic testing if we're able to get that tissue. If there are then any kind of genetic issues on that tissue, we can then go on to do parental karyotyping, so i.e. testing the mum and dad for any chromosomal abnormalities. If there are symptoms or signs or worries, we can also test for long-term glucose control by an HbA1c blood test and also prolactin. ESHRE is alone in suggesting that we should assess all of these patients by a 2D ultrasound scan for adenomyosis, that's endometriosis within the wall of the uterus. But actually in the IVF setting, all of these couples, the women will have plenty of scans, and we should have picked it up at some point during their treatment journey. And what can we do? Well, again, all 3 guidelines concur on all of these things. So as well as giving the lifestyle advice, if the thyroid function is abnormal, we should be treating that. So for hypothyroidism, we should give them levothyroxine medication. If they have positive antibodies against the thyroid, but they have a normal thyroid function test, so the TSH is less than 4, then we shouldn't be giving them treatment, but we should be monitoring their thyroid function regularly, and I would advise every 6 months while trying to conceive. If somebody has a positive lupus or anticardiolipin antibody, then we should be offering them aspirin and prophylactic low molecular weight heparin, so blood thinners from a positive pregnancy test. ESHRE actually recommends aspirin from preconception, but we would still say both from a positive pregnancy test. If a genetic abnormality comes up, then we should be absolutely offering genetic counselling to these couples, and if appropriate, then IVF using pre-implantation genetic testing may be appropriate for these couples to reduce their chance of miscarriage in the future. Andrea briefly touched on progesterone supplementation here in her talk, and that is very much part of the NICE guideline and the new RCOG guideline, but when we should be offering that based on trials such as the PRISM trial. And so there's certain scenarios that we should be offering progesterone supplementation, and especially after 3 previous miscarriages. Obviously, we're giving a lot of progesterone in the IVF setting, but it may well be there's a role to extend how much progesterone they're getting. And just as important as all of these physical things that we can do is offering supportive, both emotional and psychological support to these couples, because it's a really difficult and challenging time for them. All of the guidance suggests that we should consider resecting a uterine septum. So that's a little border down the middle of the uterus that can divide the uterus in 2, but that may not be beneficial for everybody. So it's certainly not a mandatory thing that we should be doing. And just as important as what we should be doing is what shouldn't we be doing. It's really important ethically and morally not to offer things that actually will be of no benefit to our couples. So we should not be performing hereditary thrombophilia screening in patients who have had 1st trimester miscarriages. It's different for 2nd trimester miscarriages. So these are and other sticky blood problems. We also shouldn't be offering any kind of immunological screening such as natural killer cells or providing thyroxine supplementation, even if they have positive TPO antibodies, unless their TSH is more than 4, and that's based on a trial called the Tablet trial. Endometrial scratch was quite in vogue for a while, but that's absolutely not something we should be trying or performing. We shouldn't be performing any infection screening. And all of this guidance states that we shouldn't be offering pre-implantation genetic testing for aneuploidy, so checking that the number of chromosomes within an embryo is correct. I will caveat that, however, in that the HFEA has recently changed the traffic light system for PGTA. So although it's still rated red, i.e. we shouldn't offer it, for increasing the chances of having a live birth, so a baby, for most of our patients, actually it's now rated green for reducing your chance of having a miscarriage. But unfortunately, it's still not available within NHS Scotland funding, certainly. And I just wanted to remember that we shouldn't forget the partner. And a lot of women take on recurrent miscarriage as being their fault, their problem, something that they have to change. But actually, the partner can equally do things that can reduce the risk of miscarriage in the future. Lifestyle advice is really important. They also should be maintaining a normal BMI, a healthy diet, stopping smoking, limiting alcohol. And we should be making sure they're not taking any kind of gym supplements that might be affecting their sperm quality. But the advice in these guidelines is that we shouldn't be doing, in general, sperm DNA fragmentation testing or sperm selection by physiological ICSI, or PICSI as it's called. And there's very weak evidence about the use of antioxidants. However, I was at a really great talk last week by Jackson Kirkman Brown, who many of you might know, who does a lot of work in sperm. And in those that do have sperm DNA issues, there is something called the tunnel assay, which seems to does have association with recurrent miscarriage. And varicocelectomy, so treatment of a varicocele, may improve the DNA fragmentation markers, but it can take 6 weeks to work, and 6 months, to work. And actually, he said the best advice you can give patients that may have had private screening for this kind of thing is to reduce their length of abstinence to 1 to 2 days before they give sperm for IVF treatment. I just wanted to briefly touch on recurrent implantation failure, which I know is not truly recurrent pregnancy loss, but is often felt just as deeply by our couples as recurrent miscarriage. The ESHRE group have a really helpful guideline on recurrent implantation failure, which you can find on their website. And they give this rather vague definition of it, but basically it's when the transfer of embryos has not resulted in any kind of positive pregnancy test in somebody enough times that we should be investigating it. And they do give charts in the guideline as to who we should investigate and when, in terms of age and number of unsuccessful embryo transfers. And essentially, the investigations and the interventions for RIF are very similar to recurrent pregnancy loss. So you can see here their traffic light system here. Very similar things: assessing lifestyle, ensuring we've checked for antiphospholipid syndrome, that's the anticardiolipin and lupus antibodies, doing genetic testing, 3D ultrasound scans, assessing thyroid function, etc. Not doing natural killer cell testing and other immunological things, including sperm DNA fragmentation testing. And in terms of intervention, we're a little bit more limited than we are with recurrent pregnancy loss interventions. But again, we should be making sure that their lining is thick enough, that we're making sure their lifestyle is optimized, performing PGTA if that's appropriate, but not doing anything like intralipid infusions. What's really great in this guideline is the emphasis they've put in not only the physical aspect of investigation and intervention, but really making sure that we're recognizing the couple as a whole and treating them holistically, sensitively, compassionately, and remembering the whole emotional and psychosocial aspect around having unsuccessful embryo transfers, as well as the physical side of things. I thought I would end and hopefully a little bit of a positive. Obviously, we don't want any of our couples or patients, whether they have naturally conceived or conceived via IVF, to experience recurrent pregnancy loss. But there is some advantages to having that experience within the IVF setting. And in terms of investigations, one of those advantages is that IVF clinicians are really used to managing miscarriage and recurrent miscarriage, and we usually don't have to then refer you on to a specific recurrent miscarriage clinic. We've got ready access to all the investigations that you would be recommended to have within our own setting, and that reduces any waiting times. You're not waiting to get to a recurrent miscarriage clinic and then having investigations. We can do it all in-house. Most IVF units these days will have availability and access to a 3D scanner for investigation. And a really important advantage, I think, is that we scan our patients really early. We scan them between 6 and 7 weeks. So these patients often find out earlier than you might have done in terms of the wider population who have naturally conceived. And so there's less waiting and worrying and anxiety around the pregnancy. In terms of interventions, because of the HFEA mandated requirement to have access to counsellors, we have really easy access to specialist fertility counsellors who can be exceptionally helpful for our couples who are experiencing ongoing loss. And we really lean on them a lot for help with the more psychosocial, emotional aspect of pregnancy loss. We have very easy access to progesterone, and that can't be said for all early pregnancy units. And I'm afraid locally in our early pregnancy unit, we are not providing progesterone to the NICE guidance at the minute for those with natural conceptions due to capacity issues. But that's obviously not an issue within IVF. We can give you progesterone, they're covered very easily. And in some IVF settings, we can provide PGTA. Obviously, again, that's not from an NHS funding point of view, but some self-funded centres will be able to provide that for patients.
Matt is head of department at the Newcastle Fertility Centre, and he is coordinator of the Miscarriage Priority Setting Partnership and lead author of its research priorities for miscarriage.
I'm a consultant in Newcastle. We predominantly at Newcastle Fertility Centre, we see patients throughout their fertility journey. But we also run a recurrent miscarriage clinic, so this is quite close to home in terms of my day-to-day clinical activity. Along my journey to becoming a consultant, had to take some time out to do a PhD, which is almost one of the requirements to become a subspecialist in reproductive medicine. And as part of my PhD at the University of Nottingham, I set up something called the Miscarriage Priority Setting Partnership, which is the title of my talk today. So when thinking about research and what, I suppose the first question that comes to researchers is like, what am I going to research? And traditionally, this might be the type of thing you see researchers standing around, picking their brain, thinking like, what can we actually research? So most research studies historically have been like, what do researchers find interesting? What's their pet project? What is the pharmaceutical industry funding them extra to research? So much research was kind of always led and research questions developed purely by researchers themselves. But who should we really be asking? You might recognize some of these women here, but all of them have publicly come out and said that they've had a miscarriage before. So really kind of patients, what they think is important should feed into what should be researched. And so here how do we involve patients? And so patient participation has always been something that is kind of coming much higher up the agenda, probably over the last 20 years. But is it just lip service, a token patient on a committee, asking them what their opinion is about research, or is there proper engagement in trying to find out what patients should think about? So the James Lind Alliance was set up, and the first question people always ask is like, who was James Lind? So James Lind was a Scottish doctor in the Navy, and he led what we think is probably the first clinical trial. So he noticed that lots of sailors in the Navy were getting scurvy and decided to run a trial because he didn't know what was causing it or what could cure it, where he separated out into, I think, 6 groups, and one of the groups got a quart of cider a day, another group got vitriol, whatever that is, another group got 2 oranges and a lemon, and another group had a spicy paste that they were given. And based on the result of this trial, they discovered that vitamin C deficiency was the cause of scurvy. So that's why the James Lind Alliance, who James Lind is. So the James Lind Alliance, though, was set up to create genuine patient engagement. And these priority setting partnerships follow a set sort of structure to genuinely get clinicians, researchers, and patients to work together to come up what are the important research questions in a particular area. The first one, I think, was done for asthma. There was a JLA priority setting partnership done for preterm birth, stillbirth, and so I decided to do one for miscarriage. So we set up the miscarriage priority setting partnership. We got a group of stakeholders together, which included patients, professionals, and people from other kind of important stakeholders. And we came up with this logo. One of the patients, who was also a graphic designer, and one of the key things was there can't be any red or pink in the logo. So we came up with this nice sort of green logo. So it took even quite a lot of thought to come up with this. The first step was we launched a survey which we spread on social media, and this was and also wrote out to patient groups in newsletters online, for example. And the first step was like to really get people to submit what their questions were for research. So it's collation, a survey of unanswered questions. The next step, we rank them all, and then the third step, we prioritize them. So this was the first thing we did. So how was it set up? So we initially thought like, well, who are we going to involve? So it was patients, so women who'd been affected by miscarriage, other people, so to include partners or those affected by miscarriage, family members, and then also healthcare professionals. We took a bit of time to come up with a definition for miscarriage, and I remember Sarah sort of started the evening talking about what the definition of a miscarriage was, and we agreed that we'd define a miscarriage as anything from a positive pregnancy test to a pregnancy loss before fetal survival was possible. And that's because the definition is quite difficult and it's quite sensitive, and some women, for example, like the legal definition is up to 24 weeks, but for women who lose a pregnancy far into the second trimester or beyond 20 weeks, sometimes might even be offended to have that defined as a miscarriage, because to them they've had a baby. So this was the definition that we used for the priority setting partnership. Now this is a little diagram going through how the priority setting partnership was structured. So if you think about it as sort of concentric circles, so I was leading it, and that was me, a picture of me when I was a bit younger, leading that, and the James Lind Alliance, who sent a facilitator who was impartial and chaired the priority setting partnership. The next level was stakeholders. So this was a group of people on the state steering committee, included the chair of the Miscarriage Association, the chair of the Association of Early Pregnancy Units, someone from the Royal College of Nursing, the RCOG, Tommy's GP involvement, and another patient representative from the miscarriage support group. And we also had some individual patients. So it was balanced. It was about 50% patient representatives and 50% clinicians. There were also all these organisations that supported and shared the survey. So Mumsnet, the University of Nottingham helped fund it, Birthright and NetMums, along with all these other groups, sort of sent out an email as part of their mailing distribution to get people to complete the survey. So this is how kind of, if you think about it, it starts off as a small group, but then actually we want to consult really widely and then bring it back down later on. So the first step was a survey. Basically, it was pretty simple. There was one question that said, what unanswered questions about miscarriage would you like to see answered by research? Here is a selection of some of the things that were submitted, kind of word for word. Altogether, we got 3,279 survey submissions, and we also did a quite extensive literature search to look for research questions that had been highlighted. So, for example, when people do guidelines, often they talk about research suggestions for research. So those were all incorporated into kind of our initial net to get questions in. So the next step is like, what do we do with like these 3,700? So we went through each one individually and categorized them. And these are the categories that we came up with, and the categories sort of were developed, there's a proper term for it, but by going through the questions one by one, these categories were developed rather than pre-existing ones that we did. But as you can see, like the most common question was a variation on like, why did I have a miscarriage? Like generic causation, why me? Why did it happen? What was the cause of my miscarriage? And that is probably unsurprising, but that's the most common question people have about miscarriage. Actually, interesting, the next sort of most common question was about emotional support and like what kind of support works well, how to cope with a miscarriage. The third most common were to look at prevention. And then we're starting getting down into more sort of specific things like the night shifts cause miscarriage, like specific causation sort of questions. Then about investigations, like what investigations should be done after 1, 2, 3 miscarriages. What are the chances of getting having a successful pregnancy, prognosis after a miscarriage, treatment. Are there any treatments that can help? Treatment of a miscarriage. So which one's best? Is it surgical, medical, or other types of treatment? So more research into that area. Diagnosis, like are there better ways of being able to diagnose a miscarriage earlier to try and avoid some of that uncertainty that Cheryl was talking about in the last talk. And then about systems. So for example, in the UK, we have early pregnancy units, but is that the best system to manage pregnancy loss? And then we're looking at risk factors and society, like why does society not accept, why is it still a taboo subject? Terminology, what should we change the definition? Screening, follow-up, and then is it associated with other things? And the questions about do embryos feel pain? So there's a real range of things, but this sort of sets out roughly what boxes they fell into. So once we did this, we did a second survey where we got people to rank all those areas as to what they thought were the most important. So we created summary questions that sort of encompassed all of the original submissions, and each submission was tracked to a summary question, so we didn't lose any of them. And we ran the survey again. This time we had 2,122 respondents who ranked all of the questions in order of importance to them. And then we took the top 25 in terms of ranking to a final workshop. So this is a picture of what we did on the final workshop, which we ran in Birmingham. This included 21 participants, including 11 women who'd experienced miscarriage, 2 male partners of women affected by miscarriage, and 8 healthcare professionals. And this is the JLA James Lind Alliance facilitator who ran the sessions. And as you can see, there's all these like individual cards with the 25 different priorities. And the way that day ran is sort of split into 3 groups, and we went and debated between the groups which ones we thought were the most important to come up with the top 25, and then more importantly, I suppose, the top 10. So this is us all here. So what did we finally get to? So this is the outcome, which was published on the James Lind Alliance website in an academic publication and sent to research funders, in particularly NIHR, who fund NHS research in the UK. And so the top one was, what are the effective interventions to prevent miscarriage, threatened miscarriage, and recurrent miscarriage? So even though kind of the causation was the most common one submitted, it was felt that the interventions to prevent miscarriage was probably the most important thing to research. Followed quite closely behind, like what are the emotional and mental health impacts of miscarriage in the short and long term for the mother and the partner? What investigations are of true clinical value? To what extent do pre-existing medical conditions cause miscarriage? What emotional supports is effective? Do lifestyle factors cause miscarriage? To what extent do genetic and chromosomal abnormalities cause miscarriage in the fetus? What preconception tests or interventions can you do to prevent miscarriage? What are the appropriate investigations to do after 1, 2, or 3 miscarriages? And then it was felt quite important, it nearly didn't make it in, but what are the male factors contributing towards the cause of miscarriage? Got in there as well. So I'm going to leave those up at the end of my talk for you just to have a read through. But thank you very much. I really enjoyed doing the priority setting partnership, and it was great experience kind of personally to see patients and professionals working together to achieve something like this, genuine patient engagement.
So following on from Matt now, we have our final panelist, Katy Schnitzler. Katy is information research and training lead at the Miscarriage Association. She's a researcher at the Open University's Faculty of Wellbeing, Education and Language Studies, and contributor to the book Work-Life Inclusion, Broadening Perspectives Across the Life Course.
What I'm going to be doing is sharing with you the patient perspective. So what you'll see here is evidence from people who have been through fertility treatment and then sadly miscarriage. So some of this is from my PhD research that I am almost at the end of now. I submit next February. And some of it comes from the work that I've done with organisations, so employees who have shared their experiences as well. And then, of course, from the extant literature that we have as well. So I'm just going to minimise that so I can see. Okay, so I'll try and just focus on the points that haven't been spoken about so far. So we know that miscarriage represents a physical and emotional loss for the majority of people. But what comes up a lot in the research is this element of the financial loss potentially as well, because we know that there is a financial element to this. There is also sometimes what we call, the postcode lottery. So there might not always be funding. So that is a really big factor to consider with this. So people I've spoken to have said, one of the worst things they can have kind of said to them in response is, oh, well, you can just try again. And we know that this is said to people, experiencing miscarriage when it's not after fertility treatment as well. But it's kind of an issue that exacerbates the feelings and the kind of lack of understanding that may come from others. So there's often this heightened emotional investment, if you like, after fertility treatment. And there may well have been a lengthy fertility journey, as we know. So trying for years, potentially, for some people. So obviously, when there is a loss, this intensified grief. And again, as this was mentioned earlier, it's not to minimise loss after natural conception in any way. What we do know as well is this experience is really unique. So for some people, and often people, they may assume that because you've had fertility treatment and this is a much wanted planned pregnancy, that naturally means this is going to be a devastating bereavement for you, going through miscarriage. But for some people, they prefer not to speak about their experience in that way. And it was Dr. Andrea Woolner who spoke first. She was speaking about this importance of language. And this really did come up in my research as well. So if somebody does prefer to speak about their loss as a pregnancy loss or cells or a fetus or an embryo, however they want to describe it, equally, if they use the term baby, if they use the term child, it's really important that we go with that language. It doesn't necessarily mean that it's not a bereavement equally. So this is where it can get a bit fiddly. So some people may be doing this as a kind of protective measure, if you like. They want to move forward and they don't want to kind of dwell on it. So obviously some people may have diagnosis of a fertility issue, or their partner may equally might come back as inconclusive. So this in itself can really bring about feelings of self-blame and guilt, but also this inadequacy because you've required treatment and now you've gone through a loss. So, this can be tied in with how people feel, because obviously having children can be really tied into feeling feminine, feeling masculine as well. And, if people are struggling to conceive a first pregnancy and, that pregnancy then being successful all the way through, this can be really difficult to kind of accept. There's also the issue for some people with this sense of urgency, of course, regarding age and this feeling of goodness, I haven't got time, diminishing fertility, but equally, the sense of urgency in terms of maybe there might be pressure from other people. If you've had someone in your family, a sibling, or maybe you've got colleagues, friends, they're all having babies, and you might just feel this pressure, sometimes just a societal pressure as well, to be honest. Now, we know that miscarriage is linked with mental health illness. We've got an amazing study by Farron and colleagues conducted at a London university, and they found that patients after miscarriage, so they looked 3 months, 6 months, and 9 months after miscarriage at the rates of anxiety, depression, and post-traumatic stress disorder. So what they found was actually, really high rates. So even after 9 months, this was really common, and suicidal thoughts as well. And what I would say, this is part of my original contribution to knowledge with my PhD, so it's a bit of a spoiler alert because it's not going to be published quite yet. But what we've found is that the post-traumatic stress and the suicidal thoughts, they're almost taboos within a taboo, if you like, because they're often not spoken about, with pregnancy, especially pregnancy loss. And then having IVF before that, you've got so much stigma going on here, so much silence. Now, some people may well be going through this in a couple, and actually we're seeing more and more people doing this solo as well. So just because someone's in a couple, I'd say it's important to acknowledge that the grief might be different. They might feel on different pages. They might have different access to support. People have said to me, partners, this is, that they have felt quite bypassed by support being offered to them, which is quite interesting, I think, because it feels like we should be getting better, but there's a gap here. And it was actually Black Baby Loss Awareness Week really recently. And one of the things that Alicia Burnett raises awareness of is actually the fact that there might be stereotypes applied, and there might be bias as well that we're not recognizing. So particularly in accessing support, these kind of stereotypes we might apply, for example, to, Black male partners, for example, that they're strong, they don't need support, So she does wonderful work. You've probably come across her. So also the stereotypes around doing it solo as well, and people assuming that you must be in a partnership and you've got that support. Then the decision to try again, people might not be quite ready at the same time. This anxiety, so this can be from fear of obviously another loss, but also another unsuccessful cycle, so you've got kind of double the worries, if you like. And then, of course, recurrent miscarriage. Dr. Cheryl Dunlop spoke about this in detail. And yeah, it was really great. I learned so much from all of the talks, by the way. But yeah, I think it's a really important factor, because something that came out a lot in my own research was that the more losses someone had gone through, they actually described the less amount of support was given. So that's quite interesting, kind of, they're kind of getting used to it. This keeps happening. They must be finding ways to just get through it. But obviously not the case. And this can really affect attachment and the perception of future pregnancies as well, and that fear of loss. We've got nuances as well to consider. So obviously same-sex couples, they don't have a choice but to go through fertility treatment, most of the time. So waiting lists might have been really long because of all the legal stuff as well that goes alongside that. So yeah, it can be just really difficult, again, with the stereotypes and assumptions that you might face. And then there might be some cultural and religious expectations as well. So you know, the frowning upon fertility treatment or using donor eggs, donor sperm, those kind of things. You know, I have come across that in my work as well. And of course, we've got the issues with partners bottling their emotions, perhaps going into that supporter role, so not accessing support that they need. So clinic-specific factors, and again, there's no kind of blame here, and I know this was really highlighted at the beginning, but just to kind of reinforce that. But one thing that came up, this wasn't in my research actually, but I came across this from people kind of sharing their experiences of miscarriage, IVF clinics, fertility clinics. So a few people said to me that they found it really difficult, that there'd often be success stories. So one person, for example, actually said about the walls being plastered with pictures of babies that had obviously, you know, been success stories from that clinic. And while that can be amazing and it can actually really give you this kind of reassurance, for some people, they found it very pressurizing. And actually, if they came to the end of that journey after fertility treatment, going through a loss perhaps more than once, and actually not coming out of that experience with a baby, they felt that they had no role models. There was almost a promise that this was going to happen. So again, we've got issues of minimization by healthcare professionals. And, you know, please know that I've come across some excellent examples of care as well. But sadly, this came up a lot in my research, was, you know, the sort of lack of recognition that this is a grief. Perhaps the language used, so things like failed cycle, and people might feel quite sad that, you know, they're talking about it in quite this kind of clinical way, rather than that it is the loss of a baby, you know, which many people do perceive their loss as. There was also something that came up about this kind of focus to shift to the next cycle, the next treatment cycle, that is. So maybe a pressure and perhaps not enough support. But obviously that can be meant in a positive way. But some people describe feeling a bit rushed. Obviously the confidence in treatment being affected after miscarriage, and perhaps other failed cycles as well. And we've spoken already about the financial implications of it. So for some people, it might be that they can't actually go through this again. And obviously that can be physically and emotionally as well. So this experience obviously doesn't just affect people when they're at home and then they, you know, go about their life, they meet friends, family, go into work, and it doesn't affect them in those avenues. It affects every aspect of someone's life. And one thing that came up a lot was this idea of pronatalism. So whether people kind of labeled it as that, or they didn't really know the term, but they just spoke about it. So this kind of normalization and expectation that everyone can just have children if they want them. And, you know, this is apparent just everywhere, you know, even in film. You know, I just notice it all the time because I obviously work in this field, but even things like estate agents and how they list houses at their family homes and things like that, family cars. So it's just kind of everywhere. And what participants have said to me is that this means that infertility, fertility treatment, miscarriage, and childlessness as well, they're all invisible, you know, or if they are spoken about, it's only when there's then been a success story a lot of the time. So yeah, this can really affect the support that people feel that they have. And then, of course, having pregnancy announcements left, right, and centre, it feels, you know, when you're going through this, can just be so hard to bear. There may be issues with access to counselling. So when people are offered counselling, it may be that they feel that the counselling wasn't specific for their needs. And I know it was spoken about earlier about clinics offering specific counselling, which is amazing. So it was really good to hear about that. But yeah, just some of my participants maybe didn't access that, or maybe it wasn't available to them. Some of my participants went through this during the sort of stop and start lockdowns and things. Support groups as well might provide this kind of broader support, so people might not kind of understand the nuances of going through a loss after fertility treatment. And then my specialist area is actually the workplace. So I thought I would share this with you, but work can actually exacerbate the effects, so the emotional effects, if you like, because of the lack of formal support that we often see. So there might be lack of policy, there might be lack of training, so there might be insensitive reactions, people sharing pregnancy announcements in emails, and just things like that. It just feels that, it's such a new area. So I mean, yeah, we work with organisations to help to obviously raise a platform for these issues, which, it's really pleasing that organisations are getting on board, but it is quite slow. So when there is a policy, it might exclude, so, partners or same-sex couples, it might word it quite insensitively. So just thinking about things like this, really. And then also, major finding that I've come across, and this is in other research as well, but this fear of disclosing that you're even going through treatment and that you've been through a loss, because you don't want your workplace to know that you're trying to conceive. Obviously, the impact on career opportunities, that kind of thing. So just some positive take homes, really, of things that we actually can do. So, I mean, some of these might be a bit more formal and lengthier, but some are just really what I call quite simple, and everybody can do something to kind of help the cause. So looking at language, of course, use the language that the patient or whoever's disclosing to you, it might be a friend, it might be a colleague, but yeah, use their language, mirror it back to them, because it's really validating. So if they do use the term baby, use it with them so that you're really validating that loss. Equally, if they don't, use their terms. The normalization of other experiences that are not successful as well. I think it's really important, because often people say to me that they really felt there was this promise there and it didn't come to anything, and they didn't have anywhere to turn as someone who was childless, not by choice. Being mindful of toxic positivity, so not allowing people to be angry, not allowing people to cry. Sadly more common than what I thought, to be honest, but just that kind of it wasn't meant to be, or better luck next time type thing. Obviously considering partners and the different nuances, so cultural differences, sexuality, all sorts of things we must consider. There's not like a one size fits all, and we need to make sure that we are treating people as individuals, because if someone's been through recurrent loss, or they have had a diagnosis of a fertility issue, all of these things impact on how they experience the loss after fertility treatment. So thinking about specialist counselling and obviously support groups. And we've got some amazing resources at the MA. And I know I sound biased, but I followed their work really closely for years. And I dream to work with them, if I'm honest. So now I do. I just feel like what they do is just so incredible. So they have resources, obviously, on miscarriage in all its various forms. They've got workplace bits and pieces. They've got things for healthcare. But I just wanted to really say that on their website, they've actually got stories that I would recommend you read. So they're specific stories of people who've gone through loss after fertility treatment. So they just really help our understanding, just reading that. And obviously they've got phone line support groups, and that could be really useful to recommend that to patients. And of course, we want to, change workplaces. So we want inclusive policies and training just to raise awareness of these issues. And that's part of obviously the work that I do. And lastly, just compassion and care. And that's probably the most important thing, really offering that listening ear and really giving people your time. So not looking at your phone or your watch or whatever, and people are busy, but really taking that time, because what I find is that for most people, they remember exactly what was said to them, upon diagnosis, or if they went in for, treatment after, even A&E or their own GP, but obviously fertility clinic professionals as well. So they remember what was said and they remember how the person responded to them. So just really, really important points there.
Is there a plan to update the NHS guidelines for diagnosing miscarriage following IVF treatment? For example, if a scan shows the gestation sac is, I think 5W, is that 5 weeks?
Yeah.
I was wondering if that was some measurement I've not heard of. After he was saying how tiny they were. When we know the gestation is 7 weeks. Currently, EPUs still need to confirm the guidelines of waiting a week to confirm, which can be very upsetting for people when we won't know it won't be an ongoing pregnancy. So if you could answer that, please.
Yes, I think it's a really good question. I think it's a question ultimately we don't have the answer to. I don't know if any of my colleagues on this call will agree or disagree, but I think it is a controversial issue. I don't think the guidance can change at the moment because we just don't have the evidence, and there are absolutely plausible suggestions, like you say, that where we know exactly when a transfer has happened, that therefore we know a pregnancy should be a certain stage. However, on the converse, we also know that scans have error rates, scan quality differs, and I'm not meaning to say, it is difficult because not everybody's scan will be perfect, and they never are in anyone. None of us are perfect. And there needs to be, I guess, an element of being absolutely sure before administering treatment. And we're talking more, I guess, about what used to be termed a missed miscarriage, where this isn't someone who has actively and naturally passed the pregnancy themselves. This is where we're making a diagnosis on a scan. And before we give treatment, active treatment to end that pregnancy, we do have to be sure. And I think the answer just simply isn't known. There are reports of people having ongoing pregnancies after times when they didn't after IVF pregnancies. Equally, I wouldn't want to give anyone false hope in that situation either, because that can be really difficult, and I'm always really try to be careful of that myself. But at the same time, there is I guess, a balance between also not administering treatments or medications to end a pregnancy unless we're absolutely sure. And at the moment, the evidence just isn't there that IVF pregnancy should be treated differently. On a positive, however, there is a study going on just to answer exactly that. It's being led by London, and I'm hoping we are going to join as a site, fingers crossed. I can't say too much more than that because it's not my research as such, but there is work on its way.
Well, it's encouraging to hear that even if there isn't a plan to review the NICE guideline, that there is research going on that may then inform the NICE guideline. Does anyone else want to come in on that? I think Andrea answered that quite fully.
Cheryl.
Sorry, Cheryl. Yep.
I was just going to say, I mean, this is anecdota and not it's anecdata, but certainly I've scanned women at 6 weeks and thought that is unfortunately not going to be a viable pregnancy. Scanned a week later, it's totally fine, and we are surprised all the
Same,
time.
Cheryl.
And it's really hard to say that we should be treating IVF pregnancies any differently, as difficult and as hard as that is. And we totally appreciate how that waiting game is awful, absolutely awful. But we are constantly surprised at things that happen, and we certainly wouldn't want to manage something as a miscarriage when it absolutely could be a viable pregnancy.
Okay, and it's somewhat related is this next question, which the person asking is put for you, Cheryl. They say, I wanted to ask you your thoughts on the current approach to managing miscarriage, particularly regarding the choice of treatment options. Psychologically, it can be extremely distressing for a woman to carry a non-viable pregnancy for an extended period. In many cases, after waiting weeks, a D&C is needed anyway. As a psychotherapist, I wonder whether offering early management reduces trauma.
Yeah, so I have to say, I don't know of any evidence, that's not to say there isn't, but I don't know of any evidence that treating earlier reduces trauma. Again, this comes back to often we just can't say something for certain at that time, and it requires time to play out. And eh, especially with a frozen embryo transfer, when they're already taking medication, estrogen and progesterone, we know that for the majority of people that then stop those supportive medications, they will then miscarry naturally. And actually, if we give them the medication to for medical management of miscarriage, the medication may not work as well if we start it too early. So, we stop in frozen embryo transfer. We stop the medication and wait a week, and if they haven't passed the pregnancy at that point, then we would offer management. And again, we know this is really hard, and we are not trying to delay things for patients, but every sort of checkpoint has its own delay, which for some patients can just build and build and build, and it's really difficult, and we absolutely acknowledge that.
Katy, I thought you might want to come in on this. Have you, the Miscarriage Association, got any research or have a feel for whether there is more trauma?
Yeah, certainly. There's not a lot of academic research on this when I've tried to actually look. So we're really lacking in that. But yeah, certainly studies that I have looked at. So there's one in the US and there was one in Hong Kong, and it certainly found the kind of elevated levels of trauma, going through miscarriage after fertility treatment, which I thought was really interesting, actually.
Okay, Andrea, do you want to come in?
If I may, just briefly, again, this is more anecdotal just from my experience, and I obviously see couples after fertility treatment, but also many spontaneous pregnancies. And I think in all honesty, it's just not easy. And I think that miscarriage is traumatic and sad and as I said, unexpected and all of these things that I'm not sure it's worse per se. I just think it's worse all round. Nobody wants to be in that position. And I think it can also be quite hard after spontaneous pregnancies where you've had multiple losses and where you aren't maybe eligible for things like fertility treatment because you haven't met certain criteria and so forth. I honestly just think it's just hard all round.
Yep. I agree. Moving on to a question from Jean-Barrique Parker, who asks, I'm wondering if you've noted any general differences between naturally occurring miscarriages and those occurring after IVF. I'm thinking of differences such as medical timing and degree of bleeding, etc., and psychological for the mother. I suppose one other way of framing that is if someone's presenting to you with a miscarriage, would you be able to say, well, I bet she's an IVF one or not? So I don't know who wants to go first on that between Andrea and Cheryl. Andrea, do you want to go first?
From my perspective, no, I don't think so. I mean, I think the key difference is that the pathway for people who've had an IVF pregnancy is different because they will all be offered a scan at 7 weeks. So I think how they come to the early pregnancy unit is slightly different in that sense. And obviously they have a lot of input in care before becoming pregnant, as soon as they're pregnant, and then at that 7 week point, whereas that's not the case for spontaneous pregnancies. But in terms of bleeding or whether they spontaneously pass the pregnancy or require treatment, I don't think there is a huge amount of differences, and actually would suggest, again, we maybe haven't done that research, but I don't know, Cheryl, if you are...
I completely agree. I mean, I'm a general gynaecologist as well, and I would not be able to tell you if somebody came to me with symptoms, whether it's an IVF pregnancy or a natural conception.
Oh, it's interesting. I think when I was doing some research before, I looked at Google, like a really common question, when you start to type it in, it's like, what will happen if I miscarry at 5, 6, 7, 8 weeks? And I think this is really hard, particularly for our nurses as well, who take the calls or trying to, like, people want to know what's going to happen to me. And it's really hard to predict, like, how much pain, how much bleeding. And even if you've had a miscarriage before, it doesn't mean that the same thing's going to happen the next time round. So it's quite difficult to sort of be able to counsel people as to what's going to happen. Certainly, there's no way you could tell whether it was an IVF or a natural pregnancy.
Great. Thanks everyone for that. The next question is someone who says, as a counsellor, I've met lots of women who say they've been assured by the medical team that after a first miscarriage, the risk of a second is minimal. Is there evidence to back this up, or is it untrue and misleading? And actually, following on from Katie's presentation, I wondered whether there was some slightly toxic positivity, to coin your phrase, in there. Cheryl, do you want to go first on this one?
Yeah. So what I say to patients is, if they've had a miscarriage, I say not that you've got a minimal chance of having one next time, but you're still much more likely to have a healthy ongoing pregnancy in your next pregnancy than a miscarriage. And that's a different way of putting it. And it's still maintaining a positivity, but it's not minimizing the chance that it's never gonna, it's never gonna say never. But certainly you're still gonna have a higher chance of having a healthy pregnancy than a miscarriage the next time round.
Yeah. And Matt, is that something that in the fertility clinic, how is it framed there when people ask about that sort of thing?
Yeah, exactly the same way. And I think if you look at Cheryl's chart that she had in a talk about like the prognostic factors based on your age, and even women who are slightly older, like towards 40, who maybe had 2 or 3 pregnancy losses before, they've still got a much higher chance that if they get pregnant again, they're going to have a baby than actually have another pregnancy loss. That's quite a difficult message to get across, because for the individual patient who's been through loss after loss, they kind of think, well, that's their lived experiences. Well, when I get pregnant, I have a pregnancy loss. So it's really difficult, I guess, to get that balance between trying to give something positive versus um, versus being too negative about it all, and offering that support at the same time. It can be really tricky.
Great. I'm going to move on because we've got so many questions. So someone says, I experienced recurrent miscarriages following IVF. In hindsight, I would have liked access to PGTA. It would have spared me years of emotional upheaval, avoid fertility medication and heartbreak of miscarriage. I understand the caution around add-ons. The discourse around PGTA often feels detached from the lived experience of women and our partners. Do you think we need a more balanced view, one that considers not only the clinical data, but also the human cost? Now, Cheryl, you touched on PGTA in your talk, so I'll go to you first on that.
Yeah, absolutely. And that's one of the feelings of powerlessness, I think, as clinicians, because the HFA are saying that this will reduce your chance of a miscarriage. And that is not nothing. It may not increase your chance of having a baby, but avoiding miscarriage is really important. And patients ask about it and they would like it. And even in Edinburgh, for our self-funded patients, we don't have the capacity to provide it. So I think it will change. And you're saying you're having the talk in the annual meeting about it being controversial for 20 years, and it has remained controversial. But um, yes, we often think, if that was me, I would want to know. But we also know about the difficulties with accuracy and with chromosome testing. And, just because you've got a chromosome abnormality does not mean you can't be a healthy person. So it's always tricky, but especially for, I think, the older woman with recurrent miscarriage, it would be really nice to be able to offer them PGTA, but that's a personal opinion, and I'm not going to be able to change policy anytime soon in terms of NHS funding.
Anybody else want to come on? Yes, Andrea.
And again, I'm going to state I'm not an expert in IVF and definitely not an expert in PGTA, but this is a question I'm often asked in my recurrent miscarriage clinic, and also the early pregnancy unit. And it's just a comment, really, I guess, a little bit about research. And I do think that more research is needed in this area, was point number one. And my second point was, again, just that expectations, though. And you mentioned self-funding, Cheryl, and I think I'm right in saying PGTA is an additional cost. And again, it's only available in certain places. And I think I've certainly come across this expectation. So if I have that, I won't miscarry. And again, yes, it's less in certain groups, and I'm aware of the HFEA data, but the research isn't as clear. I think we have to be, again, cautious about that toxic positivity as well, that it's not going to stop all miscarriages as well. And of course, not every miscarriage is something genetic. As I mentioned, actually, we really don't understand a lot about miscarriage, full stop. And we maybe hopefully will understand more, but we don't have all the answers, and PGTA won't be the answer in every case. So I guess, yeah, just a comment as a non-fertility expert, but who's asked this a lot. That's where I guess my head's at the moment.
I completely agree. I think people, just as some couples think that IVF means that you're not going to have a miscarriage, people assume that PGTA means you're not going to have a miscarriage, and we also need to make sure they know that. It might reduce your chance, but it's not going to take that chance away entirely.
And of course, PGTA may mean that you end up with no embryos suitable for transfer, which is also very difficult, can be a very difficult place for people to be as well. So yeah, not an easy answer to that. So a question now for Katy. So do you think there's a need for stronger psychological support during pregnancy following recurrent or late miscarriage and after IVF? While I have great respect for the work of midwives and obstetricians, many women in these situations report feeling dismissed or fobbed off when they raise concerns about their pregnancy. Could we do more to ensure that there's a clearer, more compassionate maternity pathway for psychological care?
Yeah, it's a great question. And I think the problem that, is still apparent today is just that kind of lack of follow-up care for a lot of people that go through this. So they may feel that actually when they do want to have counselling, for example, that they're actually chasing for this at a time, where they might feel very vulnerable actually. And we know that obviously there is a link with post-traumatic stress as well as depression, suicidal thoughts. We know this, but actually many people are kind of undiagnosed because of the lack of follow-up. So it's really difficult, isn't it? Because of the funding, time, capacity. But yeah, I mean, I think that just going by the study that I cited earlier, so by Dr. Farron and colleagues, they are actually saying that if people were given that immediate support, it could actually prevent, post-traumatic stress and other mental health illnesses. And, I really think that there's, clinical truth in that. But yeah, I think that we do need to do better. And lots of people come to the Miscarriage Association, for that support, which is amazing. And that is what we're here for. But actually, they talk about how it is lacking and how they weren't really given any other option.
I think this ties into another question where someone has asked, do you think the early pregnancy unit should have integrated access to counselling services? Many currently don't offer the support despite the emotional impact of early pregnancy complications. So Andrea or Cheryl, and Matt, well, you said this is next door and you've got the fertility counsellors in your clinic. So Cheryl, do you want to go first? And then
I was going to say I'm happy
go on,
to
Andrea.
but I'm happy to wait as well. I couldn't agree more. I do think that we need counselling services attached to early pregnancy units, and a bit like Cheryl was saying about many other things, we simply just don't have the funding. Counselling is provided through fertility services across Scotland and I think throughout the UK, but it is not something that is currently funded universally. And again, another issue is when we try and get such services, it's having the evidence to say that this is an effective intervention and that it's cost effective and all these sorts of things, and that's lacking in miscarriage care. Jessica Farron's paper Katy mentioned earlier is definitely a massive step towards having that information about the psychological impacts, but we are, I'm afraid, lacking in studies on interventions for psychological support. But me personally, I do think that we need that. And again, not everyone would access it. Again, it comes back to that sense that everyone grieves differently, everybody processes and manages events in their life differently. It's not to say that everyone would want to have counselling, but to have access to that, I think, would be a huge benefit. But yes, proving it and getting the money to do so is different. I wondered if I could just touch on the late miscarriage question that Katy just answered as well, that was linked to this. One of my other interests is later pregnancy losses, including late miscarriage. And I do some research along with University of Manchester Tommy Centre. And, I think, they have the rainbow clinics there for people who've had pregnancies after stillbirth. And one of the comparisons I often draw is in people who've had different types of pregnancy loss and particularly multiple early losses. They often report to me the same sorts of things in the next pregnancy that people with later losses also feel. Well, I'm the 1 in 100. I'm the one who had this complication, so I'm now worried that I'm going to have this, that, and the other. And again, I think without evidence and good studies to say that such groups need increased antenatal help, it's quite difficult to put that, and without it being in the guidelines, it's quite difficult for that to come across. I've just been involved with some research looking at late miscarriage care and including in the pregnancy after late miscarriage. So we're hoping to publish that soon. And again, it'll show, I guess, the variety of what exists across the UK. I can say that much at the moment.
And Cheryl.
The other thing I'd just like to add to that, I totally agree. Having an embedded counsellor within the early pregnancy unit would be an amazing addition. But even if that wasn't possible, having one embedded within the recurrent miscarriage clinic purely for that cohort would be incredible. But we can't even get that.
We can't get that. Absolutely. We cannot get it, Cheryl. And again, it's that lack of, I guess, proof as to why it's needed is lacking at the moment. But they are desperately needed.
Yeah. Agreed.
And Matt, did you want to come in?
Yeah, absolutely should be there. I mean, the only reason it exists in fertility is because the HFEA mandate it, and they mandated it based on little to no evidence. But because they're the regulator and they're really strict, then they can enforce it. But you don't get the same sort of regulation in because it's the CQC that regulate these sectors, and it's not as robust as the HFEA. So I'm sure if the CQC mandated, they'd have to provide it, but I think it's just a question of resources, and it's just a shame that like women's health is still massively underfunded and viewed as, well, it's just natural, get on with it, which is just completely not the approach that that we should be taking.
Yeah, well said, Matt. All the women on the panel are nodding. Great. So a question for you, Andrea, it's more of a technical question regarding progesterone levels. Do you think there's a link between high progesterone levels, e.g., less than, oh gosh, I never get my greatest and less than the right way around. So it must be more than 100 milliliters and retained products of conception. I'd be very interested in your thoughts on this.
So my answer may be a little bit dissatisfactory, I'm afraid, because I think we don't know. I don't think we know a lot about progesterone levels and impact. I think that your progesterone levels will naturally fall in a pregnancy that is ending. I think it depends if you're taking progesterone. So again, for many women who've had IVF, they will already be on progesterone. Cheryl touched on this earlier about the impacts that we think progesterone may or may not have in delaying treatment working, or indeed delaying natural miscarriage. So genuinely, I'm not sure we have the answers to that. We don't understand a lot about pregnancy levels, full stop, in early pregnancy complications. The trials that were done looking at progesterone supplementation to try and prevent miscarriage are varied in their results. But again, I don't believe that progesterone levels were measured in many of those trials, or at least they weren't published if they were. So it's difficult to know with any certainty. So honestly, I don't know as to whether or not that would mean that you're more likely to have retained pregnancy tissue. I think it's a good question, though, and I think we do need to understand more about what these biochemical markers may or may not be able to predict, or how they might be able to guide treatment decisions. But I just don't think we have the research yet. I don't know if Matthew and Cheryl think differently.
Completely agree. I have no idea. I'm sorry.
And Matt? No.
No idea. No, I
Okay.
think it'd be fantastic if we could have a test that whether it's progesterone or some other biomarker, because I think essentially the question is there any way we can reduce this uncertainty, whether it's about is my pregnancy ending, has the miscarriage been completed? It's all about uncertainty. That time is always going to give you an answer to this question, but people want to know sooner and have that closure. But we just don't have any biomarkers. Whether I think people think progesterone because that's the thing that we can measure easily all the time, but there's nothing to show. Like we can't even do any tests yet to go, look, if you've got a threatened miscarriage, your progesterone level's low, this is the reason to use additional progesterone. No, the only indication we have is a previous miscarriage and early pregnancy bleeding. So we don't have any of these markers yet for, I suppose, maybe some of the more simple questions. Certainly you can't use, I think, retained products, you really need a scan to pick that up.
Great. Okay. A question from an anonymous attendee. Most of these questions are anonymous, but this one's I did catch STIs when I was younger, traveling around the world in my late teens, and not sure if that can impact. I'm embarrassed to tell the doctor, but if you say there are certain additional tests I'll need because of my history, then maybe I'll swallow the embarrassment. So what do we think? Cheryl, what would you advise this person?
So having a previous STI does increase your risk of having an ectopic pregnancy, but as far as I'm aware, it wouldn't increase your risk of having a miscarriage. I certainly wouldn't count that as a risk factor for having a miscarriage, but it is important in knowing whether tubal function, tubal patency is correct and following a sexually transmitted infection. But that's a separate issue. That's an ectopic pregnancy issue rather than a miscarriage issue.
Yep. Anyone else want to? Matt?
I'd just try and say, like, seriously, don't be embarrassed about it. They're like horrendously common. Like 1 in 10 under 25-year-olds will have had chlamydia. So it's a really common thing. Like you tell your doctor about it, they won't bat an eyelid. It's just like a routine kind of question. While kind of personally, you may feel really like shameful about it, or it's been playing on your mind, or it might not be the type of thing you tell everyone at a dinner party. But if you tell your doctor about it, it's not something that would even like slightly shock a doctor.
Great advice. Okay, so hope you get some courage from that to talk to your doctor. So we've got a question from Gulam Bahadur, who asks, in your clinic, what aspects of the male partner do you consider alongside miscarriage? I think that was originally for you, Andrea, because it was posted quite early on, but other people might want to come on, and I know the male factor has been mentioned a few times now. So Andrea, you go first on that, and then we'll.
Yeah, and I think Cheryl actually covered this beautifully in her talk, and we use the same guidelines in the recurrent miscarriage setting, and ultimately at the moment there is a lack of evidence again around it and research around male factor. But I think Cheryl made the point absolutely clearly that the male partner is part of the equation. There's three aspects. There's the female contribution, the male contribution, and the fetal, the baby part of it as well, in terms of how this pregnancy will continue or not continue. But unfortunately, at the moment, in terms of tests or investigations, again, we're not, at least as part of our national guidance, being recommended to do anything specific other than lifestyle advice, smoking cessation. And a lot of what we advise at the Recurrent Miscarriage Clinic is what our colleagues in our fertility clinic next door advise to optimize male health. Again, the sperm DNA testing is, I guess, the big up and coming research area, and Cheryl covered that better than I could. I don't have anything to add to that. I guess I'm waiting to hear from the experts in that area as to what we should and shouldn't be offering in the future.
I think
Cheryl?
just to add to that, and I touched on this when I was talking about it, is really trying to destigmatize is this being the woman's problem and trying to take that off her shoulders, because the first question they will ask is, what did I do wrong? And most of the time they've done nothing. When in fact, every time they've done nothing wrong. And we need to remind them that it's not, as Andrea said, it's not just about them. There's other factors involved here. And it's not just a maternal age problem. There's also paternal age. And we know that the older the man is, the sperm is, that is associated with increasing issues as well. And although we can't do anything about age, it's important for them to know that this is not just, we concentrate on women's age so much in fertility. It's not just about them. And if anything, it's just to make sure that the woman knows that we can take some of that ownership she has of a miscarriage off her shoulders as well.